And are my slides visible, sir?
Yeah, it's visible.
Okay. Okay. So let me start with the. So at the outset, my sincere thanks to Inazal, Dr. Kaushal, Dr. Piran Rao, Dr. SP Singh, and the other members of the governing council. So as I said, we'll have a case-based discussion. So let me start straight away with this case. 51 years old gentleman, non-alcoholic, non-smoker, but he has history of diabetes type 2, dyslipidemia and hypertension, and is on oral drugs for almost 10 years. But his body weight has been around 50 to 55 kgs in last 10 years. And he was incidentally found to have, elevated transaminases on multiple occasions. And that was the reason he was sent to us. And on examination, he was normotensive. As I said, he was on drugs, so he was on telmisartan for this. We did his anthropometry, and his weight that time was 55 kg with a height of 168 centimeter and a BMI of 19.5, and his waist circumference was 85 centimeter. Clinical exam showed that he just had a mild hepatomegaly or a palpable liver. Rest all was unremarkable. His lab showed that his counts were largely preserved with platelet of around 1.150,000. INR was okay, electrolytes fine, renal functions were fine. His liver function showed bilirubin of 1. AST-ALT were minimally elevated with the 64 and 48 as AST and ALT. Albumin was preserved, and his lipids again were kind of normal. But as I said, he was all, and his blood sugar fasting was also normal. And as I said, he was on drugs, so he was on metformin plus sitagliptin by his general practitioner and atorvastatin for his dyslipidemia. When we looked at further at his, to rule out other secondary causes for him, we found that his viral markers were all negative. His autoimmune markers, including TTGA, was also negative. Iron profile and ceruloplasmin was normal, and ultrasound showed again mild hepatomegaly, no splenomegaly, and rest all. And obviously, there was moderate to severe steatosis, and rest all was normal. So when we looked at his severity score, which we normally do in almost all our patients, so he obviously his body weight was within normal limits. BMI, as I said, was 19.5, but he had risk factors of diabetes, hypertension, and dyslipidemia. And when we looked at his severity scores, his FIB-4 was high, NFS was high, EPRI was also high, 0.8. I think, and for the postgraduates and for the audience, let me tell you that any value of EPRI which is more than 0.7, we take it as evidence for significant fibrosis. FIB-4, again, I think there are different cutoffs, but then 2.67 is usually taken as a significant fibrosis or advanced fibrosis. Some people would take it as 3.25. NFS, again, more than 0.675 would be significant. And LSM, or the liver stiffness measurement, which we did on him, FibroScan had a value of 10 kilopascals, which would actually suggest F3 fibrosis maybe. Again, we had calculated his FAST score, which was 0.62. So let me start with with the question, and I think I will stop sharing my screen in between, or maybe I can keep my slides on, and I'll request all the panelists to switch on their videos and audios. So my first question is Professor Gauradas Chaudhary. This patient has, as I said, BMI of 19.5, but also had some of the metabolic risk factors. And he had come to us with fatty liver disease, raised transaminases, and his severity scores did show that he would have, maybe significant or advanced fibrosis. So my question to you is, for the sake of audience, if you can tell us what should be the definition of lean Nafld we should be using, and does this patient fit into that?
So, Nafld normally occurs in a setting where the body weight is more than normal. And what we consider as a body weight is that there is a normal range of BMI that's about 19, 19.5 to 25, according to the Western standards. For Indian standards, the ICMR has different guidelines. But nevertheless, the point is, we normally expect a person with fatty liver to walk into our clinic who's a little overweight or obese. If that person's body mass index doesn't fit in, then hepatologists get very concerned and they call it a lean NASH. Lean means that your body mass index is less than 25 in a place where Dr. LOOMBA practices. In India, it would be 23.5. Now, again, here there is a little bit of splitting of what is this group. So now the terminology seems to be that there is a group called non-obese Nafld. That is, their body mass index is in the normal range, so they're not overweight. And then there is a true lean, which means that they're actually lower BMI than the normal range. But nevertheless, the two are usually clubbed together. And the surprising fact here only is that this person seems to have relatively lower or normal body mass index, contrary to what we would have expected. And he has all the three other components of the metabolic syndrome. He has diabetes, hypertension, and dyslipidemia, which makes us believe that possibly the mechanism of action that has brought about his NAFLD is almost similar to that of adults. But that's the thing. The only odd point is the BMI here. And I might also just add that BMI is actually an assumption that, people with high BMI, the high BMI is due to extra fat in the body. And that premise also comes in for a bit of questioning, that whether indeed if a person with a normal BMI can have disproportionate amount of fat in the body. That's the other point that we can discuss later on. But that's the definition I would say of lean
Sure,
NAFLD.
sir. I think I absolutely agree with you. And I think, again, for the sake of audience, so if basically when we say lean NAFLD, I think the better terminology could be a NAFLD and lean, right? We'll come down to that. So, but I think anybody who has a normal BMI as per their population, this is what is the definition which people would use it. So for Western figures, it would be a BMI less than 25. For Asian and Indians, it would be less than 23. So two more terminologies which Professor Chaudhary has said is, one is the non-obese. Non-obese would actually include normal and overweight also. So they're just excluding the obese people. So here, the Western cutoff would be less than 30. And for Asians and Indians, it would be less than 25. There's another terminology called non-lean NAFLD, which means they include overweight and obese. And so they are, obviously non-lean. So, these are the three kinds of terminologies which are, used. But then, having said that, as I said, there could be some lacunae in this definition. And one could be, as I said, you can call it lean duodenal ulcer, lean diabetes, lean hypertension. It doesn't make that sense. So some people feel that the terminology like NAFLD in lean could be little better. Second problem with this definition is, as I said, this takes into account only BMI. And we know your fat could be somewhere else. So people are not talking about, the central obesity or the waist circumference. And to the extent, all the other metabolic health or the metabolic risk factors are not taken into account. And it's purely based on BMI. So that I personally feel are the lacunae, because we understand that the metabolic health is so important, right? And within the lean, you can have what we call the metabolically healthy lean and metabolically unhealthy lean. And this gentleman, I would put it as a metabolically unhealthy lean. On the other hand, in the obese people also, you can have metabolically healthy obese and you can have metabolically unhealthy obese. So I think this is a concept of metabolic health which is coming to be. So let's move forward. So my next question would be to Dr. Sameer Shah. Lean NAFLD, we have been talking now, we have defined it, and this is the gentleman which I presented. But then in your practice in journal, or can you just tell us globally or in Asia and India, what would be the usual figures for, this kind of, is it a major issue, not a major issue? So what do you think would be the prevalence for this kind of phenotype of, NAFLD?
So there has been a nice recent review in Clinical Liver Disease by Jacob George, which says that the prevalence globally varies from 5 to 26%. So there is a wide variation in the prevalence of lean NAFLD where the BMI was less than 25. In a particular country itself, like in China, the data also, one study shows 7%, other study shows 18%. in USA itself, there is a ethnic variation. So if you see African Americans, it is 11%, Caucasians 20%, Hispanics 26%. So there is a wide variation across the world, wide variation in Asian countries, and wide variation in the country itself. As far as India is concerned, we have data from Abhijit where in the general population, 5.1% had a BMI less than 23, the ones who had fatty liver. Other studies from India have seen what component of lean Nafld is amongst the entire population of Nafld. So Shivran's study showed that around 18% of his Nafld were lean, BMI less than 23. We did a study in Mumbai in Global where we looked at MR elastography and PDFF, and we found that 11% of our fatty liver were with BMI less than 23. So what have we learned with this prevalence data? What we have learned is that BMI alone is not important. If you are screening patients for NAFLD with BMI alone, you will be missing out 5 to 26% of patients who may not be having a high BMI but still have NAFLD. More important questions are, number one, do they present differently? Do they progress differently? And do we treat them differently? I think that is what the next panelists are going to answer. So I hand it over to you.
I think thank you so much. And I think we'll be discussing all these issues. But let me just quickly give you these figures here. And I picked up this very recent meta-analysis. So when we talk about the prevalence of, lean NAFLD, I think there are three ways of defining. I think I'll come down to the figures which have been given by Dr. Shah also. So one could be that you take only lean individuals and then see fatty liver disease in them. So you have those kind of studies. So here, and obviously the lean people would have less of fatty liver disease. And if you take obese people or non-lean people and you look at fatty liver disease in them, obviously the fatty liver disease would be higher in them. So this is one meta-analysis. So answer from here is that if you took only lean people, look at fatty liver disease in them, maybe 12.6% of them would have fatty liver. And if you take non-lean, it will be 26%. And within the non-lean, if you look at obese, it will be further higher. So this is one way of looking at it. The second way of looking at it is that you go to the general population and then see how many of them are, lean NAFLD, right? So again, those kind of studies are available. And again, this is a compilation of those studies. So in general, the figures again are that the lean NAFLD in Asia would be around 12%. Middle East is around 10%, and Western continent would be 9%. So thereby saying that in Asia, probably we have slightly more, lean NAFLD. But the third is, which Dr. Samisha was saying, that you take only NAFLD. And within the NAFLD, then you see that how many are lean and how many are obese. So that varies from, place to place, geographical location and various things. This particular meta-analysis gave a figure of 25%, which I personally feel is a little high. And in our practice, it is low, and I'll show you that. And this was the data he was quoting, the recent review in the clinical liver disease. So different countries, but this is minded. This is the data which is showing you that they have taken lean people, which means either a BMI as per the population less than 25 or less than 23, and then looked at fatty liver disease in them. So this is the prevalence of NAFLD in lean. But then the other group, which I said, is that you take all fatty liver disease and then see how many of them actually have fatty liver disease, right? So how many of them are lean? So this is our Go Asia data. Go Asia is our group in Asia, what we call it as gut and obesity in Asia. And this was the oral presentation in 2019, ASLD. And this was probably the largest collection of the biopsy proven patients from Asia of 12 centers, 9 countries, 1,650, patients. And, different countries have different, but here the definition used was non-obese, which I said earlier. So non-obese means for Indians or Asians would be less than 25. So here out of all NAFLD, around 18% or 19% were so-called the non-obese. Now coming to the Indian data, and I'm quoting this, I think Dr. Rohit was asking about the kind of registry if we have one. So we have a this consortium in India, what we call it as Indian Consortium on Non-Alcoholic Fatty Liver Disease. And this is ongoing since 2018. And was our interim analysis, which we presented this year in a parcel. Till date, we have collected around 5,500 patients. But this is the data on 4,300 patients, which, as I said, was presented in a parcel last month. So the anthropometry data this is a real life study. So the anthropometry data was available only in around 3,500 people. And within that, so these are all Nafld. So within that Nafld, 10.6% were so-called lean, which means the BMI between 18 to 23. So this is the overall, I would say the Indian figures is around 10, 11%. This is within the Nafld. I'm saying this is not the general population, within the Nafld around 10% lean. Okay, let me move forward. I think which the very important questions, which I think again Dr. Shah had raised. The important thing is that whether you are lean or whether you are obese and you have fat in the liver, what difference does it finally make? So that would be decided by the severity of the disease, your natural history of the disease, and obviously the treatment. So next three questions are based on that. So the first in this series goes to Dr. Shalimar. And if you can tell us, Dr. Shalimar, what do you think are the differences in severity of liver disease between lean and obese people with an FLD?
It's a two. If we say regarding the severity of liver disease, then we are looking at what kind of tests are used for assessing the severity, where we're looking at non-invasive or invasive tests. So if we look at the gold standard being a liver biopsy, unfortunately, only a select proportion of patients undergo a liver biopsy and has its own limitations. So we right now do not have well-defined, characterized studies which have really looked into prospectively looking at differences between the lean and obese. So the available data presently from the studies with whatever limitations we have and with different BMI cutoffs, as you've already highlighted, whether we take as 25 or 23, the evidence right now would suggest probably the patients who are lean may have a little less severe disease. Less severe disease, when I say, it means like on histology, they may have less amount of steatosis, less amount of ballooning, inflammation, and fibrosis also. But overall, if we look at with whatever evidence we have, this would suggest a less amounts of severe disease, but we need more prospective data to compare what is the real difference and how it really affects in terms of the outcomes of these patients.
Thank you, Dr. Shalimar. I think I'll just quickly again show you, the data from the same meta-analysis. And if you look at this corner here, and I'll not go into the details, but this is the comparison between the obese and lean Nafl. And if you look at the higher odds of NASH and its components and fibrosis, the steatosis, ballooning, NAS, fibrosis, and the liver stiffness measurement. These are all, the features of severity. They are more in obese as compared to lean Nafl. So thereby summarizing that patients with lean Nafl in general would have a milder histological disease and may also even be evident in non-invasive. Say there's the study, as I said, had a fibroscan data also. So in general, they would have a milder, severity of the liver disease. And in Asia, again, I think this is the same, data which I'm quoting, the Go Asia data from, as I said, 1,600 close to biopsies. So in this particular study, also, if you look at this, the non-obese, as I said, they use the non-obese here. So overall, the non-obese Nafl had less severe grades of steatosis and steatohepatitis. Non-obese patients were also less likely to have liver fibrosis in general. They were more F0s in non-obese. But having said that, the same study, what we had shown was that when you look at the significant fibrosis or advanced fibrosis, there was no difference. And even 1/5 means 20% of even non-obese people also had F3, F4 fibrosis. So in general, yes, we agree that I think these patients will have a milder disease, but within this group, a fraction can still have a severe disease. And this may be applicable to our patient also who's more likely probably to have a advanced fibrosis. And this is the Indian data. One study from ILBS, again, around 150 or 175 patients. They had divided into three groups. And look at the severity, the histological severity. It is, milder in lean people as compared to the obese. So the message is, yes, it is less severe, but yes, an individual patient, depending upon the metabolic risk factors that patient has, the disease can even be severe also. So coming to the next question now, which is regarding the natural history, and I think we are very fortunate to have with us Professor Rohit Loomba with us, and I think I know him for the last many years now, and we are really proud of him. The name he has made, I mean, the world over in hepatology in general and fatty liver disease in particular. And we are more proud, not because that he's obviously of Indian origin, and more than that, we are more proud that he's a Punjabi. So I would have really loved, I mean, barring this forum, I mean, we would have chatted in Punjabi, but then the forum doesn't allow me that. But so over to you, Dr. Rohit. I think the question to you is, I have actually tried to pick up maybe little difficult question for you. May not be difficult for you, but I think this is a little conflicting, area. That what is the difference in the natural history or long-term outcomes between the lean and obese people? Are there any differences? Yes or no?
Yeah, I think this is an important area. Overall, I think you already hit this issue in the head with the idea that lean individuals who have NAFLD, the disease is generally milder for the whole group. But if you look at risk of rapid progression, then there is no difference in rapid progression. So again, 15 to 20% of either of these groups may have advanced disease. There isn't much data, but one data that I think would be coming out is the leaner you are, potentially greater the likelihood that disease may have genetic basis. And so the genes might be driving it. And it's possible that you may have less protection. One particular gene, which is HSD17B13, might be one factor. It hasn't been studied well in lean, but that may be one factor that they don't have the protection there. And then they may have higher rates of PNPLA3, TM6SF2, MBOT7, GCKR, one of the disease-conferring genes, or a combination of thereof. And I think the other possibility is that they may have something else. There are rare single nucleotide genetic diseases that could affect and cause fatty liver. One of them would be inherited fructose disorders, where people have fructose intolerance. They can develop NAFLD. Typically, they are normal weight and have a BMI, somewhere between 20 and 22. Then I have also noticed some people who have mitochondrial disorders. They may be, if they're homozygotes, typically it's a recessive problem. They usually have fatigue and other manifestations, but if they're heterozygote, they potentially can have a combination of other genes and have mitochondrial disorder. They would have excessive fatigue. That's one way of diagnosing some sort of a mitochondrial problem or muscle problems, and they have a liver disorder. So I think I would start looking into genetic disorders. I have a recent review that we are writing, and that'll be coming out in Hepatology. If you have a lean patient, what all you should look for from a genetic and metabolic viewpoint when you are suspecting NAFLD. Now, Wilson's disease is another possibility I routinely test for. They can masquerade as fatty liver, although less common, I think, in India, but still you can see here in the United States. In terms of long-term outcomes, we really don't have data on long-term outcomes differentiating between lean versus obese, but my gut feeling is that the risk of progression would be lower in lean compared to obese. obesity and diabetes being a major driver of fibrosis progression.
Okay.
Ajay, you're muted.
Yeah, I know they had muted the. I think the host had muted me anyway. So now I think we've rightly put up the about the natural history. So I'll just quickly showing maybe 2 or 3 studies on this. This is the Chinese studies, Hong Kong from Vincent Wong's group, which was published in Hepatology 3-4 years back, and there they had this paired kind of biopsies in a small number of around 80 patients. And what they showed, and also they had the LSM, and this was the kind of follow-up. They said that the relative rate of disease progression is probably lower in non-obese, 6.3 versus 31%. The regression was not different, but the progression was lower in this thing. But then, the one is the histological progression or regression, other could be the clinical events. So in the clinical events, what they found was that when they looked at the deaths, there were 6 deaths, all were in the obese group. There was 2 HCC, all in the obese. 1 liver failure, he was also obese. And also the cardiovascular events were also happening more in obese. Again, they were giving us an idea that yes, the clinical outcomes were also a little better in lean in comparison to the obese. But then having said that, this was one controversial abstract which never came as as a full paper, DDW 2014 multi-center study, where they had taken these 480 patients, followed them up, and they said that the lean group actually had a lower cumulative survival, right? So I don't know, but then this never got as a full paper. But then this was another study which was again published in Hepatology Communications, and they looked at again the mortality and the severity of liver disease. So they said mortality there is no difference, but then the lean people, on follow-up of around 19 years, they said around 640 biopsy proven, lean people can have, little severe liver disease on follow-up, right? And so I think there was little, kind of, I would say, conflicting data, what could be the natural history in them. But finally, this was the enhanced data, which was around 5,000 lean people, and they divided into non-Nafld and Nafld. So this study said that even if you are lean, but lean with Nafld is worse than having only lean without fatty liver disease. Which means if you're lean with Nafld, your overall all-cause mortality and your cardiovascular mortality is more than the lean person who doesn't have fatty liver disease. So I think that's another message. So the progression data I thought was little conflicting.
The time is, I've been warned by your organization.
So this is my last question to Dr. Dharmesh Kapoor, that how will you manage liver disease in this person with lean Nafld? And then I will stop. Dr. Dharmesh Kapoor, please.
Thanks so much, Dr. Ajay. That's a wonderful case. Just to add that when we are handling patients with lean NASH, maybe the family history or familial clustering of either liver disease or hepatocellular cancer also becomes very important in us having a low threshold for managing these patients. Now, in the given case, we have been told that the waist circumference is normal. This patient is already on 3 drugs, which is metformin, sitagliptin, and atorvastatin, and we have only one cross section of the values available, and which are seemingly normal, though I would go with the much lower LDL than what is there in this case, which is 100 on treatment. So I think this person does not have visceral adiposity. Some patients with lean Nafld will have visceral adiposity, and in them, there might be a relevance of driving home the fact that exercise and diet have a huge role to play. But once the patient walks into your clinic, you have to suggest something to them, otherwise they will go to another doctor. So I think exercise and diet would be the important message that one would want to give to this patient. However, with this august audience, I would again like to say that in this category of patients, probably a low fat and low cholesterol diet is something that you would want to drive home, because the pathophysiology is a little different from the garden variety of obese Nafld NASH that we see. So I think low fat, low cholesterol diet. In others, we always talk of low carbohydrate, low fat diet in that order. This patient, again, we have to counsel them regarding use of alcohol. And of course, the Western literature differs from the alcohol consumption that is permissible to what we use in our country. Drugs I have already mentioned, I would try to drive home the LDL much lower. The two things that come to mind apart from the genetics, which has been very elegantly discussed by Dr. Rohith LOOMBA, is A, the role of gut microbiota in this disorder, and two, our general reluctance to use insulin resistance as a criteria for treating these patients. So there is one good study with the use of symbiotics in patients with lean Nafl, which has shown some benefit. And again, it's believed that gut microbiota might have a greater role to play in this category of patients than the other Nafl NASH patients. And I think pioglitazone again is a drug that one should probably be thinking of in these patients, especially when they have visceral adiposity, which we are able to demonstrate at baseline. The best tool for which, of course, is MRI. So that would be my additional inputs.
Yeah, I think, thank you, Dr. Ramesh. I'll just, I think he rightly said, I mean, whether somebody is lean or obese, first and foremost thing is the control of all these metabolic risk factors, which he has: diabetes, hypertension, dyslipidemia. And for that, I think Dr. Pankaj will, put a second round of questions to all the panelists. Exercise, we know, is very, very important, even if you are lean. And the choice between drugs, because he has fibrotic NASH, pioglitazone, vitamin E, and Sero, but he's also a diabetic. So I don't know, vitamin E may not be a good choice. So the choice would be between Pio and Sero, but both have really not shown good data as far as anti-fibrotic action is concerned. So we are little handicapped as far as, he's, as I said, the LSM is 10. He looks to be having significant or advanced fibrosis. Which drug to use? I think we can have some discussion on this. So the time doesn't permit me to get into the details. So I'll now hand over to Dr. Pankaj Puri to take up from here and ask the second round of questions to all the panelists. Thank you. Let me stop sharing my screen.
Thank you, Ajay. I'll also share my screen. Just give me a moment. This is not doing the slideshow. Just give me a second, please. Yeah. Good afternoon, everybody. I'll be giving you a view from the other side. So far, we've been focusing on looking and trying to prevent liver damage and improve the liver. But most of these people have multiple other comorbidities, and metabolic syndrome is part, and insulin resistance are part and parcel, which goes along with NASH. We need to focus on the other parts of the metabolic syndrome, which include hypertension, their diabetes, their hyperlipidemia, because most of the morbidity and mortality will come from cardiometabolic side. And we can't say we will focus only on the liver and the patient going to come to us and we have to look at the other things. So I'm going to ask you questions and address topics where we look at these individual factors, and in treating these individual factors, if we can improve the liver, so be it. That would be an added bonus. So the first question is to Dr. Gurdas Chaudhary, and what would be his viewpoint on choice of antihypertensive therapy, if any, in a patient with NASH?
I think there are several groups of antihypertensives, but the two which seem to be reasonably good for treating patients with NAFLD are the ARBs and the ACE inhibitors. I realize that this patient is already on telmisartan, which is an ARB, and I think that seems to be what most people who deal with metabolic disorders would like to agree upon. So I think that would be the one. The other ones, which are like calcium channel blockers and diuretics and all, are better avoided, and he probably doesn't need them. So I think if he's controlled with telmisartan, I'm reasonably happy with that.
Let's click on this. Okay, so the ACE inhibitors and the ARBs are probably the preferred treatment modalities. They may have an anti-fibrotic effect as well. They would suppress hepatic stellate cell transformation into myofibroblasts, and they may also regulate hepatic fat by induction of PPAR gamma. And there are some studies which show that there may be some anti-fibrotic effect of these drugs, but we need larger and controlled trials to show that they can be primarily the treatment for NASH. While that may not so be proven, they may be having some additional value. The second question is to Dr. Samir Shah, and this is about use of statins. Very often patients come with some derangement of liver enzymes, as was there in our patient and patients in statins. So what would be the response? And very often the statins are stopped even by the cardiologist because the liver enzymes are deranged. And how would he choose the other lipid lowering drugs, whether they would have any value in NASH?
So very rightly, I think it has been pointed out all throughout today's webinar that lowering lipids in patient who has dyslipidemia with NASH is the prime strategy in dealing with patients with NAFLD because it prevents the cardiovascular risk. Statins are underused, as you rightly pointed out, Pankaj, for the fear of hepatotoxicity, even by cardiologists and us. Because number one, now we all know that statins are safe to be used and they are recommended even up to child A cirrhosis in patients who need them. So statins per se are not for treating NASH, but if a patient with NASH has dyslipidemia, even with child A cirrhosis, you can safely give statins. And if you underuse them, then actually you are exposing your patient to the risk of cardiovascular toxicity, cardiovascular morbidity. So the important question is if there is a patient with NASH and elevated liver enzymes and dyslipidemia, how do you choose? So amongst the drugs which lower lipids, is there a choice? So the other drugs apart from statins are niacin, which is also sustained release can cause actually the highest risk of hepatotoxicity. Ezetimibe and fenofibrates, they were considered safer, but even them, there is a rare reports of either autoimmune liver disease or cholestatic liver disease. Amongst the statins per se, there is nothing really to choose from. Either they may be lipophilic or hydrophilic, but it doesn't really, there is no data to say any one statin is less hepatotoxic than the other. So the question comes up, if you have a patient with elevated liver enzymes and dyslipidemia with NASH, you start statins. Many a times the liver enzymes actually come down because you have treated the patient properly with controlling dyslipidemia. So that is one thing. If the enzymes continue to remain elevated, that is the whole question. Whether we should switch over to saroglitazar is one question which remains unanswered. We don't have really data on that, but that is a question which we need to answer, whether statins have a proven track record as far as reducing cardiovascular risk. If you ask the endocrinologist colleague, they are not gung-ho about saroglitazar because of lack of data on reducing cardiovascular risk. And they are not very enamored by saroglitazar as far as its reduction in the LDL levels. So these are the two issues with saroglitazar. But in a patient who has persistent elevated liver enzymes on statins, whether we should switch over, I would put this up to the rest of the panelists and Rohit as far as the question is concerned. Over to Vivek.
So there is a suboptimal treatment of dyslipidemia in patients with NAFLD, and this was a study which came out in 2020, which highlighted that we weren't treating enough of hyperlipidemia. The cardiologists have gone crazy. The American College of Cardiology will even give you LDL values of less than 55 as the target in people who have extreme high risk factors. And if you have high triglycerides, then your choice would be the fibrates and the omega-3. But if the primary goal of management is LDL and cholesterol, then your baseline backbone therapy is statins. The other things, if the LDL still remains high, whatever the goal we choose, whether it's 100 or go as low as 55, then you add ezetimibe or the Pcsk9 inhibitors. So there has been studies to show the efficacy and safety of statins. This was the Greece study, which enrolled 437 patients with NAFLD. and showed that these had decreased cardiovascular morbidity without significant liver-related adverse effects. And there is some data to also show that it may improve liver steatosis, inflammation, and fibrosis, while not being enough for it to be a primary treatment modality for NASH per se. What about the other lipid-lowering drugs? Estimide acts by decreasing cholesterol absorption by the intestines. And in a meta-analysis, it's been shown to improve steatosis and hepatic ballooning, but not fibrosis. Fenofibrate, again, will act only basically on triglycerides, and it did not improve liver steatosis. The omega-3 polyunsaturated fatty acids have been shown to have some effect. Mainly, they decrease triglycerides and VLDL, and they may have some anti-inflammatory effects, but the effect is small, and the doses and duration of therapy is not yet established. Pcsk9 inhibitors, again, data is not enough to say that they will improve NAFLD per se, but they may. As far as saroglitazar goes, it will act on PPR alpha, and that will be a little bit like fenofibrates. They'll improve the triglycerides more and not act as much on the cholesterol and the LDL. Next, and a lot of this has already been addressed by Dr. Rohith about the role of anti-diabetic drugs in management of NASH, and if you would like to add anything more. Lost Rohith somewhere. Is Rohith there? Hello? Well, I think he's not there, so I'll just carry on a little bit. These were the basic drugs which are used in diabetes, and we look at their cardiovascular risk reduction, the effect on fat, and the effect on liver histology. Pioglitazone will decrease the cardiovascular risk, they have effect on liver fat, and there has been some improvement in liver histology. The GLP-1 receptor agonists and the SGLT2 inhibitors will both decrease cardiovascular risk as well as liver fat. The DPP-4 inhibitors, which are the gliptins, have been neutral on cardiovascular risk. Only vildagliptin has been shown to have some decrease in liver fat. So these are the basic drugs. So that's why GLP-1 and SGLT2 have been in focus as additional therapies besides pioglitazone for treatment of NASH. Of course, this was recently alluded to. This is a recently published paper on the improvement of NASH with semaglutide. But again, there was not enough improvement in fibrosis. But we need to see whether fibrosis is an end result of inflammation and may improve with time. So maybe if, as the authors have written in the paper, that maybe if you follow them up longer, there may be improvement in fibrosis as well. So this is a question to Dr. Dharmesh about choosing an anti-diabetic drug in patients with NASH. How would he choose anti-diabetic drugs?
So Dr. Pankaj, for me, the treatment of a diabetic patient with NAFLD NASH remains pretty much the same as a patient without this syndrome and diabetes, and metformin is the most important drug that I would consider. Most of these patients are type 2 diabetics. And then if there is not a significant decline in the A1C, I would add the DPP-4 antagonist. And then the third choice would be the SGLT2 inhibitors. I did see the earlier table in which you mentioned the benefits from SGLT2 inhibitors, but I would still go with the algorithm of metformin first, followed by DPP-4, followed by SGLT2 inhibitors. And then, of course, there is a lot of noise about the recent New England publication of semaglutide, which is available in our country now as a once weekly preparation, though a much higher dose. And then the benefit that it might have for this cohort of patients, both with the reduction to A1C as well as weight loss, so which is one of the key drivers of our therapy with NASH. So almost 13% of weight loss from baseline occurred in patients who received 0.4 milligrams semaglutide on a daily basis. So that would be my policy in treating these patients' diabetes.
Thank you. As correctly mentioned, metformin is really the initial preferred pharmacological agents. We would choose early introduction of insulin if they are catabolic, if they have very severe hyperglycemia. We must keep the other factors, the cardiovascular and renal comorbidities, the hypoglycemia risk, and costs and patient preferences and side effects in mind while choosing the therapy. This was the ADA guidelines which have been published this year. If you have a person with significant heart disease, heart failure, CKD, SGLT2 are preferred. In the absence of these, we have to look at factors like risk of hypoglycemia. Is the liver disease significant? Are they obese? Do we need to lose weight? And of course, cost. If you're looking at cost, the cheapest ones are sulfonylureas and the PIOs as the cheapest ones. If you need to maintain weight, the GPLP1 and the SGLT2 inhibitors are the ones which would be the ones to focus on. The last question to Dr. Shalimar of choosing anti-diabetic drugs in a patient who has NASH and cirrhosis.
I think, sir, I'll go with what Dr. Dharmesh has said. The sequence would essentially remain the same. So we're looking at, as you rightly also said, there are other associated problems with renal failure, associated hypoglycemia, other complications. So we need to keep in mind, especially in a cirrhotic patient. Now also depends which childhood class the patient is. Child A, I'm happy with the same sequence as what sir has mentioned. B and C, I would be careful. You've got risk of complications occurring, need to be very careful monitoring of their sugars. And in the end, sugars are not being maintained. Definitely insulin is there to back up on. So that would be my take on anti-diabetics in cirrhotic NASH.
So there are many challenges in the management of a diabetic patient who has cirrhosis and decompensated liver disease. There's difficulty in monitoring them. The HbA1c levels may be fallacious. They may be having hypoglycemia. They may have hepatic encephalopathy, which may affect their self-management. And of course, drug metabolism, renal dysfunction, risk of lactic acidosis, hepatotoxicity, these are all important factors to consider in mind. So on the left are the basic group of drugs. And the right side, we have the recommendations as per child A, B, and C. If you look at the patients who are in child C, almost very little other than insulin is safe. We can try a little bit of metformin in child C. Some SGLT2 inhibitors, there has been some data that will improve their ascites and fluid control as well. But most of the safest of the lot probably is insulin, because that's where the data is maximum. The metformin can be used in lower doses, and usually would be 500 to 1,000 and maximum 1,500. PIOs we would avoid in decompensated cirrhotics because they would be in advanced liver disease because they would cause fluid retention, worsening of osteoporosis. Sulfonylureas, again, very high risk of hypoglycemia, we need to avoid them. My favorites would be DPP4 inhibitors, and among them, the linagliptin is probably the one I would prefer the most. It has a primary renal excretion, and that's one reason why you would prefer that. SGLT2 inhibitors are good drugs for ascites control, but we have a risk of genitourinary infections in these patients. So I guess we need to look at the child score, the individual risks of hypoglycemia, weight loss, renal dysfunction while choosing these drugs. And if you have a patient who's a cirrhotic, who's compensated, we would look at hypoglycemia, the obesity, the presence of renal dysfunction, because renal dysfunction means we can't have very lower glycemic targets, and the renal dysfunction, all these factors while choosing drugs. If they're decompensated, low dose metformin, some small dose of linagliptin, SGLT inhibitors, and probably the safest of the lot is insulin. So NASH is really an interrelated disease which has multiple little focuses besides hepatology, and we have to look at the patient from what is good for his heart, what is good for his weight control, what is good for his sugar control. Unfortunately, in India, we can't, for one patient who's coming with NASH, we can't send him to 5 specialists, and we need to address each of these factors, keeping the liver as well as the cardiac morbidity and mortality in focus. Thank you. I would stop here and hand over to the chairpersons.
Thank you, Pankaj. Well, there are some certain burning questions, obviously, by various people. I think all of you have addressed the management of fatty liver disease as well as various associated comorbidities very well. But I will start the ball rolling by asking a very pertinent questions. Because if you see patients with fatty liver disease, irrespective whether they are non-lean or lean or non-obese or obese, about 1/3 of them are diabetic. And they are treated by endocrinologists. They receive insulin therapy, both various types of insulin, not necessarily soluble insulin, but various long-acting insulin as well. Now, do you think long-term insulin in patients with advanced fibrosis in this group of people has the increased risk of developing liver cancer, hypoglycemia, and other complications? Because none of you mentioned details about insulin therapy and its effect. And it's a very practical problem in a sizable segment of patients with various grades of fatty liver disease. I'll ask the panelists, starting with, well, Rohit is there and Dharmesh is there, all of you are there. What do you think? Because you see practically a large segment of patients being treated with insulin. And Pankaj,
I think the question that you mentioned is a very relevant question, sir, and this probably should have been answered in literature many decades ago, and maybe this is a case that one can pick up with Dr. Rohith LOOMBA. So insulin, we all know, is a carcinogen, so there is no doubt about that. This is not just in the context of the Nafld-Nash syndrome, this is in various other situations that the human body is exposed to. And obviously you have to minimize the use of insulin as much as you can, and that is why the use of insulin in the current scenario should be limited in patients who've got other alternatives to treatment. Having said that, when patients have got decompensation and they still have got poor glycemic control, and they are predisposed to all kinds of infections, skin soft tissue infections, so on and so forth, in the context of decompensated cirrhosis, we all go with insulin therapy. That is the best treatment for these patients. The long-acting insulin has got a lower propensity to produce hypoglycemia. You get almost steady levels throughout the 24-hour period. But if somebody's food intake is very erratic, what I do in my practice is to just use short-acting insulin and ask them to take it post-meals and educate either the patient or someone in the family to titrate the dose of insulin. So we are not going for a good glycemic control here, but that is what I would do in my practice. So insulin should be used sparingly. There is no denying that.
Do you think, Dharmesh and other people, that fasting insulin level in these patients, if you measure, and invariably, even though there is no prospective study, you will find clinically they are quite high and indicating insulin resistance?
Of course, there is insulin resistance. So in all the categories of patients that you described, there is.
I'm asking a question. Does it really influence your therapeutic decisions? Unfortunately, these are questions I'm asking intentionally to experts because the prospective studies, like many other aspects, are lacking.
So that is what I okay, let Dr. Rohith take that. Sure.
Okay, Rohit.
So I think there are two issues. One is I agree that hyperinsulinemia, so when somebody's body is producing more insulin, that's pro-growth, and that would have a higher risk for future development of obesity-associated or insulin-resistant associated cancers. I'm not sure if insulin therapy would cause cancers. I think the state itself, diabetes and hyperinsulinemia would be a pro-growth state. Now, to treat it, we've got multiple options. I agree that insulin is not the greatest option, but it will be necessary in certain cases where insulin sensitizing therapies may not be enough, or if people have extreme beta cell failure. So some patients need insulin for their treatment of diabetes, and they would need so. Again, there are two kinds of insulin depend. In particular, insulin would lead to weight gain, so it would be problematic in NASH, and we would want to avoid that. You could pair it with another drug, which we routinely do, metformin in early patients who don't have beta cell failure. Beta cell is still intact, and you could use it. Then we use SGLT2 inhibitors that also can induce some weight loss. You could lose glucose through the urine, you could reduce your insulin utilization. And then GLP-1, but they're so expensive, many patients are not able to afford it, but they could potentially be utilized early on, you lose weight, and then you could use less insulin or no insulin. So that's sort of how I view it. In some patients, it's necessary, you can utilize it. There are two kinds of long-acting insulin. One is basal insulin, BIL, that definitely increases liver fat. The other types of insulin, such as Lantus, that's routinely available now, long-acting, is not that bad. And in certain patients, you need it, so I would utilize it over using it 3 or 4 times a day, because the risk of hypoglycemia potentially might be higher with frequent dosing than long-acting with a set dose, and then whatever else you need, you might use on top of it. Those are sort of my thoughts. In terms of therapeutic, yes, I think we definitely utilize that idea in combination therapy approaches. So lanifibranor is one drug, as I mentioned, which is a pan-PPAR agonist. The other one, of course, pioglitazone is there. That's why we're thinking of combining insulin sensitizing therapies with those that don't have any effect on insulin. For example, ACC inhibitor has no effect on insulin, but might improve lipotoxicity, reduce de novo lipogenesis. Same way, there are drugs that may improve lipids, such as, say, thyroid hormone beta receptor agonist. Insulin sensitizing effect is low, so potentially they could also be combined. So I do agree that from a combination therapy approach, it is important to note that whether our patient has insulin resistance or not. Vitamin E, for example, doesn't modify insulin sensitivity. So it is not beneficial in people who have extreme insulin resistance. In fact, they'll continue to worsen on vitamin E. So we might need other therapies to improve their insulin sensitivity.
Thank you, Rohit. There is a question now in the chat box I must address to the panelists. There is a question, if the trans mRNAs becomes normal, do you think the patient should continue the treatment or he can stop the treatment if there is a persistent normalization of trans amino acids in a clinical practice in a patient who has NASH with F2 or F3 fibrosis, and in a patient who has NASH with less than F2 fibrosis? They are different groups of patients. In them, will you continue drugs? As you have discussed a host of drugs, and particularly certain clear drugs. And if you so, what is the duration of therapy with such patients?
Yeah, I think in this case, it depends on where the patient started in terms of their ALT. We have a paper with Jay Hufnagel in APNT. Then I wrote a paper on predictors of treatment response, which was in gastroenterology, showing ALT improvements and histologic response. The key thing with there would be what is the baseline? Suppose they're starting at 80 units ALT and it goes down to below 30. That patient is a responder, and you could stop treatment. What you need to do is, after stopping treatment, you want to recheck ALT, AST in about 3 months. If the ALT, AST start going back up, that means it was the drug that was modifying it. The disease state hasn't modified, so you might need therapy again. The only patients in that study, it was a follow-up of Prevalence trial, those could maintain normal ALT despite taking off the drug, were those who lost weight and had lifestyle intervention along with the medications. So if your patient actually lost, say, 5% body weight, but was also on treatment, or maybe 3% body weight, but is exercising, that would be an ideal patient to stop the drug. I have stopped many medications on my patients who would give weight loss along with pharmacotherapy.
What will think the other experts? Do you all stop in India? Dr. Rohith says that he sees the patient, he stops the drug, must follow them up, and it is associated with weight loss, significant weight loss, and the transaminases remains normal. He stops the drug in them. And what are the other experts? Do you think in Indian experts, do you stop it, or you reassess such patients with various non-invasive tests to assess their fibrosis as well as fat scores. What will be the Salimar? What will be your option?
I would like to continue and see how is the response. Losing weight is what we very uncommonly see in our clinical practice, patients losing weight. So if all parameters have settled down, we'll still like to follow. And then yes, if the transaminases remain normal, then yes, we can take a call for stopping drugs. That would be my take on that, sir.
Okay. Do you stop it, Dharmesh?
I think even before that question, when you start therapy in a given patient who's asymptomatic and in whom you tell him that probably his life is going to be shortened in more than one ways, the first question he asks you is, how long are you going to treat me? And that is a commitment you have to make right at the outset rather than depend on the ALT. So for me, it would be at least 2 years as of now. And generally, I still prefer doing biopsies so that one is on a firmer footing. But I would say that weight loss, like Shalimar says, is not so common, at least to the extent that we know can reverse fibrosis. And therefore, I would be...
So Subrad, may I add on something?
Yeah.
So just now the available drugs, whatever we are using, they are all for either dyslipidemia or diabetes, which is not going to go away.
That's
So
right.
so you will have to continue for treatment of diabetes or treatment of dyslipidemia unless you are so sure, like what Rohit said, that you have lost weight, you are maintaining your lifestyle, and you have corrected your basic metabolic problem. You have got rid of your diabetes, you have got rid of your dyslipidemia. Only then the question comes of stopping drugs. Most of the times, as soon as the patient recovers, again in a few months the weight gain comes up. So it's a question of continuing the drug because we are continuing to take care of the metabolic syndrome.
I'm grateful to all of you.
So can I ask a question, sir?
That is the metabolic health which Ajay pointed out from the beginning. So the treatment of fatty liver disease, irrespective of underlying spectrum of the liver disease, whether to continue or not to continue, because usually combination therapy is an important variable is metabolic health. So, and if metabolic health is controlled by lifestyle modification, well, you can think about discontinuing drug. That's what the summary is coming. Yes, Ajay.
This is a question to, again, Dr. Loomba and to all the experts here. Let's talk about this index patient who looks to be having advanced fibrosis. Right? His diabetes, his lipids, his hypertension is well under control. He has no weight to lose. His BMI is only 19. So how do you tackle his liver disease? That is my question to you. We don't have any good antifibrotic drugs for him. OCA is not approved, not available. I mean, it's available, but not approved, right? So other than that, vitamin E you said is not a good option for him. So within PIO, again, is side effects and, not shown to be good antifibrotic. Same is the issue with Saro. So what option do you have? You can't leave his advanced fibrosis like this. His lifestyle modifications is only exercise. That's it. So what do you do?
I think, so whenever the patient walks in, I'll give you one example of a particular patient which will fit into this domain. I always try to find out what is the driver of disease in this patient. And the driver is sometime in the history, sometime in the labs. I have found patients that they are sometime taking certain things they think that will benefit their liver, not knowing it. Some people are juicing it. I have patients who were drinking juices 8 times a day. And she had CML and she was taking fresh juices 8 times a day to improve her health, all organic, thinking it'll improve. And she developed NASH, and they wouldn't give her chemotherapy because her ALT and AST were 150. And so I treated her, I stopped all the juices, and I treated her with both combination of, this is 5-6 years ago, with vitamin E 800 and pioglitazone together. And and she's, of course, changing her diet. In 2 months, we had significant normalization of her ALT, and she started her chemotherapy back. This patient, I think, is BMI of 19.5. I'm concerned that his diet is predominantly carbohydrates. And so I will try to modify his diet and also try to see if genetically he's predisposed or if he has some other factor that is contributing to his fibrosis and steatohepatitis, may it be alcohol or excessive sugar consumption in terms of colas, sodas, something that he's taking. And some people may be taking hepatotoxic medications for their liver. In the United States, we have people who are exposed to petroleum and they have toxin-associated steatohepatitis. Say they work in benzene-associated factories or are living closer to those areas where water might be polluted. So thinking something about those might be helpful. But I'll treat him probably with a combination with vitamin E and pioglitazone. He could benefit from vitamin E because his insulin resistance is not bad. And pioglitazone, that the only downside is weight gain. And in his case, with BMI 19.5, that's not too bad to try PO. So I might use a combination of that.
Thank you.
Okay, thank you. There is another question. We have 3 minutes left. I will address this question. So maybe this is the last question or last two questions. One question is, you have already discussed that lean NAS or non-obese fatty liver disease or NAS has probably less severe disease. Number one. Number two, you also discuss once they have a fibrosis, the natural course in them remains similar as obese NAS. Third question, which was not addressed and somebody has pointed out, do lean NAS or fibrotic NAS, which is the treatment targeted group, behave similarly to available therapy as you have shown in registration trial and some limited drugs which has been cleared to be used in clinical practice. So is the response rate similar? Benefit similar? Right.
Yes.
That is a question.
The response, so based upon Prevalence and Flint, it's unpublished data, but we know from NASH CRN, in lean, the response was similar to obese. And so actually, they're more likely to respond better. And so their response would be better because you'll be getting more drug into the same body weight. So they do respond very well to vitamin E and also PO.
So the answer is response is much better in those patients with lean NAS with fibrosis, and therefore they should be treated well. And the last question I will address, many of these patients had this comorbid disease, and again a clinical problem, many of them has renal dysfunction, various grades of renal dysfunction. Cardiovascular disease is a different thing. Cerebrovascular disease is a different thing. Associated cancer is a different thing. Renal problem is very common. And mild renal function with a serum creatinine more than 1.5 to 1.8 will hover around over a long period of time. How do you treat? Is the treatment same? Are some drugs to be avoided? Is there a modification for this drug necessary like many other drugs? That's the question.
Yeah, I think so if they were diabetic, first thing you would avoid with a creatinine of 1.5 would be metformin, potential risk for lactic acidosis. Then some of the other drugs have renal receptors. So FXR has renal expression. I would potentially be using less in future. Now they're not approved yet, but less of that. Even PPAR alpha. So any drug that has PPAR alpha activity, potentially in renal disease, there's a potential signal there as well. But drugs like vitamin E, I think would be pretty safe and shouldn't have any problems in terms of changing in the dosing, for vitamin E. But you could still use pioglitazone, especially low dose pioglitazone would still be fine. Although I would tend to avoid things like fenofibrate that are predominantly PPAR alpha.
Thank you.
So only
Yes,
thing
yeah.
maybe I would like to add is I think we in our experience, I think we published that a few years back, and the meta-analysis show that again the occurrence of CKD or renal impairment in patients with fatty liver disease, other than the metabolic risk factors, is also dependent on the severity of liver disease. So if you have NASH, if you have advanced fibrosis in the liver, I think your risk of having renal impairment and CKD would be high. So I think it's very good to keep control on your liver disease so as to prevent the occurrence of renal impairment.
Thank
Can I
you.
make a quick point, sir? Taking from what you had said a little while ago, Dr. Rohit, two things: OCA in lean NASH, and two, the semaglutide trial and the signal towards malignancy or neoplasms in general. That is what Dr. Acharya's first question was.
Yeah.
OCA in lean NASH and semaglutide study.
The obeticholic acid data in terms of response to therapy is not different based upon body mass index or based upon obese versus non-obese. So the response is similar. In terms of the risk of cancers, we don't think that there is any data suggesting that FXR agonism would increase future risk for cancer. So that's not an issue. GLP-1, I think, again, overall, I don't see future risk for cancer. Some people in previous studies were worried about potentially pancreatic and other, but overall, because of weight loss, we see significant CVD benefit and at least neutral on future cancer risks. Potentially, it will be beneficial on obesity-associated cancers for GLP-1 or semaglutide.
We are over. Now the time is over. It is my job to thank you, each of you, including Rohit, Samir, Dharmesh, Ajay, Salimar, Pankaj, and Professor Chawla, Jayanti, and all of you, including our organizer, General Secretary, Kausal Madan, who have provided a very stimulating Sunday feast. And thank you very much. I think what I learned, in 2 minutes, I will summarize. Ajay started the ball rolling, telling us the fatty liver disease, the phenotypic or anthropometric phenotypic is now being splitted, or hair splitting is occurring. It started with obese fatty liver disease. Then we brought in lean fatty liver disease. Now we are calling it non-lean fatty liver disease and non-obese fatty liver disease with certain definition. Have a heart, my comment. Don't confuse people. You are experts. You are day in and day out into it. Make life easy for you. That's the first request to the panelists. Now further confusion has brought in by a certain group of people, calling it MFL. Because of this controversial, they say it is a metabolic syndrome which is causing this. So no question of obese, no question of lean, call it MFL. That's another problem. But you are not thinking about large populations of people who are seeing this day to day in their general practice without understanding this nomenclature and their clinical relevance. My first question. The second, what I learned, irrespective of all this definition, the frequency of metabolic syndrome